Good morning, ladies and gentlemen. The topic of today's lecture is bacterial infection. Since this is a big chapter, I am going to deliver a few lectures that will comprise of different parts of this chapter. So today's lecture will be mainly the introduction of bacterial infections and introduction of staphylococcal and streptococcal infection. And I will be discussing three important bacterial diseases, that is Impetigo, Ecthyma, Cellulitis and Erysipelas. So let's proceed for today's lecture. Normal flora of the skin. The dry skin supports low level of colonization, whereas moist areas, that is, especially those which are supplied with sebaceous glands, are heavily populated with normal bacterial flora. Most organisms resides on the surface of stratum corneum. The hair follicles are inhabited by Propionibacterium deeply and Malassezia on the surface. So the hair follicle bear both bacteria and the fungi or candida. There are, however, no bacterial inhabitants of sweat ducts or glands, acrine or apocrine glands. So there are two places where the normal bacteria flora is present, either in the stratum corneum or in the hair follicle. The resident flora consists of Staphylococcus saccharolyticus, Micrococcus species, gram-positive rods like Corynebacterium, and gram-negative rod like Acinetobacter. Staphylococcus aureus should not be considered as a resident on healthy skin, although it is frequently found in the interior nares. It occurs there as a resident in about 1/3 of most population and is carried on the perineal skin in perhaps 20% of the population. On the damaged skin, for example, eczema or psoriasis, Staph aureus may be found sometime widely over the skin surface. So usually Staphylococcus aureus is not a part of normal resident flora, but is carried in the interior nares in a special population in more than 30%, sorry, one-third of the population, and perineal skin in 20%. In already inflammatory skin diseases like eczema and psoriasis, staphylococcal colonization is more frequent. Quantitative studies. The population of micrococci per square centimeter of skin have been estimated as 600 for hand, 60 for forearm, 300 for scapular region, and 500,000 to 1 million in axilla. The total anaerobic organisms average 1.46 into 10 to the raised power 6 for the scalp, and 2.41 into 10 to the raised power 6 for axilla, and 3.8 into 10 to the raised power 4 per follicle. So it's a huge number. The modifying factor. Abstinence from washing does not increase the count. Taking a shower probably produces a brief and temporary reduction. Increase in external temperature and humidity increase the bacterial load. Carriage of Staph aureus may also be affected by cold weather, duration of hospital stay, or needle injection. The antiseptics applied to the skin as in preparation for operation generally removes the transient flora and reduce the resident organisms. So it is important. The role of normal flora. The defense against bacterial infection through the bacterial interference. This is the first and foremost role of the normal flora. That presence of the bacteria there, it interfere the colonization of the virulent bacterial strains. Produce free fatty acid from the skin lipids, which inhibit the growth of other organisms like Streptococcus pyogenes. The apocrine sweat is sterile and odorless when secreted. The odor develops due to the bacterial action, mainly the aerobic Corynebacterium. Deodorants are effective largely through their antibacterial activity in the eczema. Flora of the specialized area, the nasal vestibule. The common organisms found are coagulase-negative Staphylococci, micrococci, and chroniforms. External auditory mediators. In addition to the coagulase-negative Staphylococci and chroniforms, Proteus species Escherichia coli, Neisseria cataralis have been isolated. Axilla. Mostly Staphylococci, micrococci, and chroniforms. Toe cleft. Toe web is an important site for Brevibacterium and Acetinobacter. Umbilicus. In newborn, it is frequently colonized by Staphylococcus aureus shortly after birth, and also by Streptococcus pyogenes. The vulva. Organisms include coagulase-negative Staphylococci, micrococci, and chroniform, with coliforms and enterococcus. Group B Streptococci may be cultured. The perineum and groin. Coagulase-negative Staphylococci, micrococci, or aerobic chroniform Acetinobacter species are resident in about 15%. Adherence. These are usually specific and interact with the host cell via receptor site. Example of bacterial additions include lipotecoic acid found in both Staph and Strep. The secretion of extracellular material such as slime allow bacteria to adhere to foreign surface as well as to stratum corneum. The skin and the defense. Skin provides a dry mechanical barrier from which contaminating organisms are constantly being removed by desquamation. The chemical mechanisms are responsible for destruction of Streptococcus pyogenes, whereas drying is responsible for destruction of Escherichia coli and Pseudomonas aeruginosa. Both factors contribute the elimination of Staph aureus. The chemical mechanisms include unsaturated fatty acid, particularly oleic acid. Presence of a virulent strain prevent the colonization of virulent strain by competition of available nutrients. The organisms also produce bacteriocins. These are the antibiotic substances which may inhibit the growth of other bacteria. The skin participates very actively by producing antimicrobial peptides such as cathelicidin and various defensins by the keratinocytes. So the role of normal stratum corneum is multiple in preventing the bacterial colonization. Gram-positive bacteria. Staphylococcus aureus. Staphylococcus aureus is gram-positive and coagulase positive. This is the most important cause of skin infection and of serious and sometimes fatal systemic disease. Wide use of antibiotics results in selective survival of resistant strains. Carriage. The carriage of Staph aureus on the skin, the main site is anterior nares in 35%, perineum in 20%, axilla in 5 to 10%, and toe webs in 5 to 10%. Contamination from carriage site is common, notably of the hands from the nose. Within the nasal passage, the anterior nares are the most readily colonized part and are the site which is usually sampled. Patients with HIV infection and AIDS-related disease have higher carriage rate of Staph aureus. Intestinal carriage of Staph aureus is particularly common among the hospitalized patients, and this may be associated with transmission of organisms to the skin. Suppression of carriage of Staph aureus. So the nasal carriage of Staph aureus is physiological, and not in itself an indication for the treatment. The reasonable indication of treatment is those that would render staphylococcal dispersal a significant hazard to others, such as doctors and nurses, and patients suffering from frequently staphylococcal infection. So only the eradication of staph carrier is mandatory in healthcare workers who can spread the disease to others, and in those individuals who are suffering from recurrent staphylococcal infection. Permanent eradication of Staph aureus is not possible, but temporary elimination can be done. Long-term application of chlorhexidine cream to anterior nares, perineum, or axilla, or povidone iodine for daily bath are effective, although recolonization occurs soon on stopping. Intranasal mupirocin eliminates nasal Staph aureus after a 5-day course in all patients. 50% remain free of the organism after 5 months. Oral rifampicin 600 mg daily for 7 to 10 days cleared the organism for 3 months in 80% of cases. Good result is also achieved with clindamycin 150 mg daily for 3 months. Bacterial interference. Nasal inoculation of low virulence strain of Staph aureus 502A causes bacterial interference against more virulent strain. However, this can cause fatal septicemia, so it is not an advisable option. Colonization of diseased skin by Staph aureus. In atopic eczema, Staph aureus can be isolated from 91% of the chronic plaques and 100% of acute exudative lesions. Number of Staph aureus correlate with the severity of eczema. Patient taking retinoids may develop cheilitis and blepharoconjunctivitis, often associated with Staph aureus infection. Biologically active substances which are produced by Staph aureus. So Staph aureus produce various different toxins. The first is the exfoliative toxin, also known as epidermolytic toxin, ETA and ETB, epidermotoxin A and epidermolytic toxin B. These are responsible for generalized staphylococcal scalded skin syndrome and bullous impetigo. Then another toxin which is produced by Staph aureus is TSST1, which is toxic shock toxin that is involved in toxic shock syndrome. Then erythrogenic toxin in staphylococcal scalentina. Then penton-valentine leukocidin is a cytotoxin causing septicemia, skin necrosis, and severe necrotizing pneumonia. Staph aureus superantigens have a role in evolution of atopic dermatitis. Resistance to staphylococcal infection. The main host defense against invading staphylococci is ingestion and killing by phagocytosis. Antibodies to various Staph aureus antigens are universally found but are ineffective. So resistance to staphylococcal infection is reduced in patients with poorly controlled diabetes, renal insufficiency, acquired immunodeficiency syndrome, hematological malignancies, nutritional deficiencies, or alcoholism, and those who are receiving corticosteroids or cytotoxic therapy. Predisposition to staphylococcal infection. Immunoglobulin deficiency, including selective IgM deficiency and certain deficiencies of complement system, may contribute to staphylococcal skin infection. In Shirek-Higashi syndrome and chronic granulomatous disease, deficiencies of granulocyte function predispose to staphylococcal infection. Cyclic neutropenia is associated with recurrent infected eczemas. In Job syndrome, there is increased incidence of severe staphylococcal infection associated with eczema and markedly raised IgE and defective neutrophil chemotaxis. Staphylococcal and other infections are associated with eczema in Wiskott-Aldrich syndrome. Involvement of Staph aureus in cutaneous disease. So direct infection of skin and adjacent tissue by Staph aureus causes impetigo, ecthyma, folliculitis, frunculosis, carbuncle, psychosis, and occasionally cellulitis. Secondary infection can occur in eczema, infestations, and various ulcers. Then cutaneous disease that are caused by staphylococcal toxins, they include staphylococcal scalded skin syndrome, toxic shock syndrome, staphylococcal scalentina, and recurrent toxin-mediated perennial erythema. There is also evidence that high bacterial density, that is over 10 to the power 6 per centimeter square on lesions, significantly aggravates the eczema. Recently, importance of staphylococcal superantigen have been investigated, and following exposure, T and dendritic cells are recruited to the area and induce inflammation. One of the chemokines expressed is CC chemokine ligand, leading to recruitment of pro-inflammatory cells, and hence the superantigens have a role in aggravating or potentiating the eczemas. Antibiotic resistance. Of special importance is the gentamicin resistance, which can be transferred between strains of Staph aureus. Hence, gentamicin should not be used as a first-line topical antibiotic in staphylococci. Similarly, fusidic and mupirocin resistance have been reported widely. Methicillin-resistant Staphylococcus aureus or MRSA. Once established in hospital, the survival of this strain seemed to be promoted by the widespread use of antibiotics. Resistance to antibiotics occur when an organism acquires a gene that allows the microbe to inactivate the antibiotic. The MRSA carriage on the skin may persist for years and increases the risk of spread if patients who are carriers are readmitted in the hospitals. Majority of the infections presents with abscesses or folliculitis. Identifying patient with MRSA in an attempt to reduce exposure to other patients and treating appropriately. Vancomycin is traditionally being used as a drug of choice for treating these, but treatment has to be given intravenously and duration of hospital stay is prolonged. So many strains are still sensitive to trimethoprim sulfamethoxazole and tetracycline. Linezolid is still currently beneficial for MRSA. Then coagulase negative staphylococci. Staphylococcal epidermidis is the main pathogen of the group. Occasional cause of minor skin infection, for example, superficial folliculitis. It may cause infection in wounds, especially around implant surgical devices. It has been increasingly recognized as a cause of endocarditis, septicemia, and especially in patients with immune deficiencies. So multiple antibiotic resistance is common in even coagulase negative staphylococci. Then the Streptococcus pyogenes. Streptococcus pyogenes is the second most important gram-positive cocci and is one of the major streptococcal pathogen in humans. And it is mainly subdivided in M and T surface protein antigens. The streptococcal pyogenic exotoxin, which includes the erythrogenic toxin, play an important role in endotoxic shock, and superantigens effect on immune system result in massive cytokine production. So these are the diseases or list of diseases which Streptococcus mainly of group A causes. So direct infection of skin or subcutaneous tissue, impetigo and ecthyma, erysipelas and cellulitis, vulvovaginitis, perianal infection, streptococcal ulcer, blistering distal dactylitis, and necrotizing fasciitis. Secondary infection results in eczema, infestation, and ulcer. Then the tissue damage due to circulating toxin includes scarlet fever, toxic shock-like syndrome, and recurrent toxic-mediated perennial erythema. Then some skin lesions that are attributed to allergic hypersensitivity to streptococcal antigen. They include erythema nodosum and vasculitis. Then skin diseases which are provoked or influenced by streptococcal infection, the mechanism is uncertain. So the first is guttate form of psoriasis and second is the Kawasaki's disease. Carriage. Streptococcus pyogenes is carried in throat in about 10% of normal population and anterior nares less frequently. Normal skin does not provide a favorable habitat for Streptococcus pyogenes, perhaps due to partially to bactericidal effect of skin lipid. Asymptomatic anal carriage is occasionally source of significant infection in contacts. Streptococci colonize the damaged skin, although less readily than Staphylococci. Initiation and complication of infection. It is widely assumed that skin damage, although minor, is necessary for development of naturally occurring streptococcal pyoderma. Once organisms have adhered, they are capable of upregulating the expression of inflammatory mediators by keratinocytes and producing streptolysin O. Rheumatic fever is a complication of Streptococcus pyogenes pharyngitis. Acute glomerulonephritis follow both throat and skin infection with certain nephrogenic serotypes of Streptococcus pyogenes. Tics, Tourette syndrome, obsessive compulsive disorder, and attention deficits have all been linked with streptococcal infection. Erythema and gutted psoriasis are known to follow streptococcal throat infections. Streptococcal serology. The anti-streptolysin or ASO titer is an indicator of previous infection by Streptococcus of group A, C, and G. The upper limit of normal is 200 units per ml. In streptococcal skin infection, the ASO titer response is weak and unreliable guide for diagnosis. In some countries where streptococcal infection is common, the ASO titer may be persistently elevated, hence it may not be an indication of a recent infection. The molecular basis of identification of bacteria has made diagnosis easy, but until it is available to more laboratories, standard serology and culture continue to confirm the diagnosis. Impetigo. Impetigo is the first disease we are going to discuss today. It is contagious superficial pyogenic infection. Two main clinical types, bullous impetigo and non-bullous impetigo. Bullous impetigo is accepted as the staphylococcal disease. The non-bullous form is caused by staphylococci, streptococci, or both organisms together. Some use the term pyoderma to apply to the streptococcal disease, reflecting the clinical differences between the two forms, and others regard pyoderma and impetigo as synonyms. So this is a diagrammatic representation in which a vesicle is seen in impetigo here and is situated just underneath the stratum corneum, and it contains the neutrophilic exudate. The right half of this slide shows an ecthymatous ulcer. The pustule destroys the keratin layer, but also erodes the epidermis to invade the dermis. Organisms can be generally cultured from the blister fluid. Injection of bacterial isolate from the affected patients into a newborn mice result in generalized staphylococcal scalded skin syndrome. The exfoliative or epidermolytic toxin has been recovered from the blister fluid. Epidemiology. The pure staphylococcal non-bullous impetigo is relatively frequent throughout the world, and large outbreaks often occur. In warmer and more humid areas, streptococcal form predominate. The preschool and young school age children are most often affected. Overcrowding, poor hygiene, existing skin condition predispose to this infection. In newborn, bullous impetigo may be especially widespread and was formerly called as pemphigus neonatorum, as it resembles the clinical picture of pemphigus with widespread blistering. The clinical features. The non-bullous impetigo initial lesion is a very thin-walled vesicle on an erythematous base. The vesicle soon rupture and is seldom seen as such. The exudating serum dries to form a yellowish brown crust. The crust eventually dry and separate to leave erythema, which fades without scarring. Face, especially nose and mouth and limbs, are the site that are commonly involved. In bullous impetigo, the bulli are less rapidly ruptured and become much larger with diameter of 1 to 2 centimeter and persistent for 2 to 3 days. After rupture, superficial erosion or flat brown crusts are formed. Although face is often affected, the lesion may occur anywhere. Note the vesicles are covered with golden yellow crust. These perioral lesions are characteristic site. So this is one of picture of my patient showing the yellow brown crust and superficial erosions with some intact pustules. Bullous impetigo. There is large raw erosions and a healing lesion distally. If this extends, it can lead to full-blown staphylococcal scalded skin syndrome. So histology shows of bullous impetigo shows line of cleavage immediately below the granular cell layer. In addition to neutrophils, occasionally acantholytic cells are seen, and here it causes diagnostic confusion with pemphigus foliaceus. Complications. Cellulitis occasionally occur with streptococcal disease. The streptococcal impetigo accounts for the majority of cases of post-streptococcal acute glomerulonephritis. Scarlet fever, urticaria, and erythema multiforme may follow streptococcal impetigo. Treatment. In mild and localized infection, a topical antibiotic alone is sufficient. Good results are achieved with mupirocin or fusidic acid in both staphylococcal and streptococcal impetigo. If infection is widespread, an oral antibiotic such as amoxicillin, clavulanic acid, or clarithromycin is indicated. When hand washing was promoted, the prevalence of impetigo dropped significantly. Then comes the ecthyma. Ecthyma is a pyogenic infection of skin that is characterized by formation of adherent crust beneath which ulceration occurs. The bacteriological status of ecthyma is essentially similar to that of impetigo. It was formerly regarded as the streptococcal infection, but now coagulase positive staphylococci is seen in 85% of the cases. Poor hygiene and malnutrition are the predisposing factors. The clinical features: lesions show hard crust of dried exudate with indurated base. In impetigo, it is a soft yellowish brown crust. In ecthyma, it is hard and black crust. The crust is removed with difficulty, and if removed, reveal a purulent irregular ulcer. Healing occurs after a few weeks with scarring. Buttock, thigh, and legs are commonly affected sites. You can see this slide. There are multiple ecthymatous lesions on the leg. Histologically, there is a thick neutrophilic crust overlying a sharp ulcer. This is the neutrophilic crust. Treatment: improved hygiene and nutrition, and treatment of underlying disease. If the infection is widespread, an oral antibiotic such as amoxicillin, clavulanic acid, or clarithromycin is indicated. Then comes cellulitis and erysipelas. Cellulitis is strictly an acute, subacute, or chronic infection or inflammation of loose connective tissue. Erysipelas is infection of dermis and upper subcutaneous tissue. So both the diseases, they differ in the level of skin involvement. Both diseases have similar bacteriology and demonstration of streptococcal antigen in both dermis and subcutis. So cellulitis and erysipelas is mainly a streptococcal disease. Bacteriology. Bacteria are present in affected tissue in small numbers An attempt to culture them from biopsy material and even from the fluid from the blister are often unsuccessful. Cellulitis and erysipelas are predominantly streptococcal disease involving group A organism. Staph aureus is occasionally isolated. Other bacteria that cause cellulitis include Haemophilus influenzae type B, Streptococcus pneumoniae, Pseudomonas aeruginosa, Campylobacter jejuni, Vibrio alginolyticus, and Pasteurella multocida. Clinical features. Cellulitis is characterized by all the signs of inflammation that include erythema, heat, swelling, pain, and tenderness. In erysipelas, an additional hallmark is a well-defined edge and raised edge, reflecting the superficial nature that is involving the dermis, and cellulitis, on the other hand, is diffuse. In erysipelas, blistering is common. Some cellulitis may show bully and can progress to dermal necrosis and uncommonly to fasciitis and myositis. So cellulitis should not be taken lightly. Cellulitis, note the widespread erythema and lower leg is the characteristic site. It is mostly unilateral and quite painful. Erysipelas is characterized by well-defined edge and superadded blisters. Leg is the commonest site. Next common site is the face. Lymphangitis and lymphadenopathy is frequent, and there may be fever and malaise. Without effective treatment, complications are common, which include fasciitis, myositis, subcutaneous abscesses, septicemia, and in streptococcal cases, nephritis and more severe infections. This is the skin necrosis and deep ulcer as a complication of cellulitis. The childhood facial cellulitis due to Haemophilus influenza type B is typically unilateral, affected cheek or periorbital tissue show induration, discoloration, and characteristic purple-blue color. Orbital cellulitis is common sequelae to sinusitis. In addition to cutaneous sign, proptosis, ophthalmoplegia, and loss of visual acuity may occur. Periorbital and orbital cellulitis may be complicated by cavernous sinus thrombosis, cerebral abscesses, or meningitis. The recurrent streptococcal cellulitis or erysipelas cause lymphatic damage which predisposed to lymphedema. Then is the diagnosis. Serological studies may provide evidence of streptococci and less commonly staphylococci. An initial Hay titer may suggest at the diagnosis. The differentiating cellulitis of leg from deep venous thrombosis, phlebography, plethysmography, and Doppler ultrasound may be helpful. Cellulitis is unilateral, while erythema nodosum is bilateral and several lesions. A cluster of cases closely resembling cellulitis, but bacteriologically negative and unresponsive to antibiotics may attribute to insect bite, plant toxins, or rarely viral or fungal infections. Treatment. Appropriate antibiotics should be given in full dose by intramuscular or intravenous route in more severe cases that are associated with septicemia, arthritis, or suspected fasciitis. In all cases, the initial treatment should cover streptococci, and for the facial infections in young children with Haemophilus influenzae. Flucloxacillin exhibit a bactericidal effect on streptococci as well as staphylococci. For this reason, it is suggested as the oral monotherapy 500 mg 4 times a day or clarithromycin 500 mg twice daily is substituted in case of penicillin allergy. It is customary practice to combine flucloxacillin with benzyl penicillin intravenously 6,000 to 1,200 mg 6 hourly intravenous in more severe cases. The treatment should be continued for longer if there are any clinical indication of cellulitis. The anticoagulant therapy should be considered if there is associated thrombophlebitis. The treatment ladder then, first line is flucloxacillin, clarithromycin, clindamycin, and benzyl penicillin. Second line is roxithromycin and prophylactic treatment of recurrent infection with penicillin and erythromycin. So this comes to the end of today's lecture. Thank you for your presence and hope to see you next time with next edition of my lecture on bacterial infection. Goodbye for today and have a good day.